everyone to our latest presentation on colloids. The colloids, that is the synthetic colloids, were mainly developed during the time of the wars. In the World War I time, gum arabica, a natural colloid from the acacia plant, which was a polysaccharide, was the first synthetic compound to be used as a colloid. In the World War II, the commercially available synthetic colloid, that is polyvinyl pyrrolidone, was developed by Professor Walter Rippi in 1939, and in clinical practice it was introduced by Helmut Weiss. There are two types of colloids, natural and synthetic. Natural is albumin, synthetic is dextran, hydroxyethyl starch, and gelatin. Dextrans are neutral, high molecular weight polysaccharides. They are developed from Nuconostoc, mesenteroides, or dextrican. Most dextran molecules have a molecular weight less than 50 kilodaltons and they are excreted by the kidney. A small amount is stored in the RE system. The advantages of dextran are it is low cost, can be stored for a long time, in glass bottle up to 10 years, it lowers the viscosity of the blood, reduces factor VIII activity, antithrombin activity like unfractionated heparin, and it has a higher molecular weight prolonging intravascular effects. The disadvantages are it has contraindications in severe congestive heart failure, renal failure, hypervolemia, or hypersensitivity. It can cause osmotic kidney failure, anaphylactic reaction, interfere with the erythrocyte cross matching. More than 1.5 gram per kg per day can result in bleeding. Currently, it is withdrawn from the German market. The next is gelatin. Gelatin is produced from bovine collagen, where initially it is heated. After that, there is cooling done, resulting in what is called the raw gelatin. It has a mean molecular weight of 30 to 35 kilodaltons. The advantage is it is inexpensive, minimal effects on coagulation. However, the major disadvantages are rapid urinary excretion, facilitate red cell aggregation, and the rate of anaphylactic reactions is highest. Up to 1 in every 1,000 patients receiving gelatin develop some kind of anaphylactic reaction. The next is hydroxyethyl starch. HES was synthesized for industrial purposes since 1934. However, in 1957, Wedersheim used it for experimental plasma substitute, and extensively it has been used in the Vietnam War for volume resuscitation. Raw material is amylopectin, which is derived from either waxy maize or potato starch. This multi-branch structure makes it the first synthetic colloid with a globular configuration similar to the natural colloid albumin. HES has much lower viscosity than dextran and gelatin, but does not reach the low viscosity of albumin. Starch, that is the amylopectin, is produced first by the hydrolysis, then by hydroxyethylation, and finally the ultrafiltration, resulting in the final product. These sites, that is the oxygen sites, are the places where the substitution is mainly done. The mean molecular weight is slightly higher, from 70 kilodaltons to 670 kilodaltons. The hydroxyethylation is mainly attached to the C2 and the C6 position of the glucose chain. So a common prescription is 6% has 130 by 0.4. What does it mean? It means that its solution of 6% has in normal saline. Usually normal saline is a diluent in which the 6% has is dissolved. The mean intramolecular weight is 130 kilodaltons, and the 4 hydroxyethyl residues per 10 glucose molecules are the substitute, that is the 0.4. The next is the C2 by C6 ratio. A higher molecular substitution and a higher C2 by C6 ratio makes the HES molecule less susceptible to plasma amylases. It decreases the blood viscosity. The waxy maize consists of 98% amylopectin, and the potato starch composes 75% amylopectin and 25% amylose. Potato is more viscous with low C2 by C6 ratio. Potato starch enables the formation of inclusion complex with several endogenous lipophilic molecules. So if you look at the anaphylactic reactions, as we have seen, the highest is with gelatin. And the next effect, that the most common side effects with the colloids, is the hemostatic effect. If you look closely, the hemostatic effect with albumin is negligible, with HES 0.4% is negligible. Other dextrans, gelatins, HES above 0.4 has quite significant hemostatic effects. The last but not the least, the most important effect is the renal function. Mm, The studies since 1960s have shown dextran-induced renal failure. This is owing to the tubular obstruction by the swelling and the vacuolization. As you can see over here, there are a lot of lysosomes which have been vacuolized by the uptake of these colloids. These are the four major RCTs which have been published comparing HES with crystalloids. The first is in severe septic. The second is the chest trial in ICU patients, again crystal in all ICU patients, bicep in severe septic patients. So most of them have shown a higher risk of renal replacement therapy and death. Now we will come to the natural colloid, that is albumin. It is a single peptide chain composing of 585 amino acids with a globular structure with 66 kilodalton molecular weight. It has three homologous domains that form a heart-shaped molecule. It is water-soluble, negatively charged, non-glycosylated, high capacity for binding water. 60% of the total protein present in the plasma is albumin. It is 100% produced in the liver, majorly degraded in the muscles, liver, GI tract and kidney. It has got a median half-life of 18 days. The main physiological effects are it maintains the colloidal osmotic pressure. Apart from this, it helps in transport of endogenous and exogenous substances, antioxidant and free radical scavenging property, anti-inflammatory, anti-apoptotic and antiplatelet effects are also seen. In critically ill patients, it helps in volume resuscitation, improves liver function, used in blood loss and for leaky capillaries. Now let's look at the albumin story that we know so far. In 1941, the first clinical use of human albumin solution in patients was done in multi-trauma and circulatory shock. In 1943, the first reported case of human albumin in 200 patients was published. In 1975, the first RCT trial of human albumin in 16 patients was published in abdominal aortic surgeries. However, everything changed in 1998 BMJ trial. It was basically a meta-analysis. The risk of death in albumin-treated group was found to be significantly higher than the comparison group. The pooled relative risk of death in albumin was 1.68 and the pooled difference in the risk of death was 6%, or 6 additional deaths were attributed to albumin in every 100 patients who had received the treatment. So they considered to use human albumin solution in critically ill patient should urgently be reviewed and we should stop the use of albumin. So basically the meta-analysis put into question the very usage of albumin in any kind of a critically ill patient. So based on this, the US FDA issued a Dear Doctor letter to all healthcare professionals expressing serious concern over the safety of albumin administered in critically ill patients. Based on this, the SAFE trial was initiated, which showed a similar outcome in 28 days, thereby removing the concept of any kind of higher risk of mortality with albumin compared to saline in fluid resuscitation for critically ill patients. So if you look into the subgroup analysis in head injury patients, there was increased mortality. Apart from that, in severe septic or ARDS patient, there was no effect on mortality. The next was albumin replacement in severe septic or septic shock. This was not a resuscitation trial. This was basically to keep a level of albumin by infusing albumin. In this, a significant difference was observed in the post-crop subgroup analysis, and this was done in 1,121 patients in septic shock. And in here, they found an improved SOFA score and in improved subscore of cardiovascular SOFA. Albumin was safe for use in critically ill patients. Utility as anti-inflammatory is not yet established, and as of now, other colloids are not recommended for fluid resuscitation. So, for all practical purposes, synthetic colloids are out. Is it? Not really. This is because, as you can see, a lot of interest recent years has developed to the balanced salt solution and the renal toxic effects of increased chloride. As you can see over here, all these starches are dissolved in some kind of a solution, and the solution that is most commonly used is normal saline. So if it is 6% Hess, it contains the rest is normal saline. So when we find an increased RR of renal risk, that is a relative risk of RRT, it doesn't mean that it has to be completely attributed to hydroxyethyl starch. It could be because of the increased chloride that is being given, because the comparative groups, as you can see over here, mostly consists of balanced salt solutions, and one of the major trials did not find any difference in terms of death and mortality. So as of now, we can say that the role of colloid is not completely out. And this is one important trial which was published in 2013 in anesthesia, the effect of intravascular volume depletion and the lung and kidney damage following resuscitation with various fluids. In this, a non-septic model of experimental ARDS, 25% of blood volume was withdrawn and it was resuscitated with ringer acetate, gelatin and hydroxyethyl starch. As you can see over here, the lung injury was highest with ringer's acetate, and the kidney damage was highest with gelatin. So gelatin and Hess were associated with less lung damage than RA, and gelatin was associated with more kidney damage. So the only fluid which was quite good in terms of both kidney and lung protection was Hess. So we can say that the role of synthetic colloids is still not properly out. We need more focused studies to look at these type of indications. So thank you for your patience, and check our website for further information.